without further ado, I'm going to introduce our upcoming speakers. So we will be transitioning to the ACAP panel. They'll be talking about the learning collaborative that they have and the insights that health plans have gained. So on that group, we have Enrique Martinez Vidal, who's the VP of Quality and Operations at ACAP. We have Richard Bolduc, who is the VP of Technology and Analytics for Health Services with Children with Special Needs. Kim Sinclair, the CIO at BMC HealthNet Plan. Mike Boeder, who is the Executive Director of Healthplan Operations at CCHP, which is the Children's Community Health Plan. And then Khoa Nguyen, who is the President and CEO of KN Consulting. So looks like we have you guys all on already. So feel free to show yourselves on video, unmute, and Khoa, maybe you can take it away.
Oops. Hi, everyone. I'm Enrique Martinez Vidal. I'm actually going to change my background to be my real place. So thanks, Ricky and Christina and the team at One Up Health for the opportunity to provide some insights into what our organization and our member plans are doing to implement the interoperability rules. It's really an honor to be here. So unfortunately, Richard Bolduc was not able to join us at the last minute. So it's going to be Kim, Mike, and Khoa. I'll introduce them in a minute. My colleague Asfia is on. She's going to share her screen, actually. We're going to start out with a couple of slides to set the stage here for what we're going to talk about today. So let's see if she can do that. She might need to have the ability to share her screen. Okay, she does not have permission yet. I might be able to do that myself. Let's see here. Oh, wait a second. There we go. Today we're going to talk, I'll give you a little bit of background on who ACAP is and what some of our interoperability activities have been so far. Then Khoa is going to talk about our interoperability learning collaborative. He's our consultant for that work. And then we'll get some plan insights on the ground from Mike and from Kim. And I'll introduce them when we get to that part. So the next slide is really who ACAP is. So we're the Association for Community Affiliated Plans. They're all nonprofit plans. They all have to have Medicaid plan contracts with their states, so they're all Medicaid MCOs. Some are in the Medicare market. Some are also in the marketplace, the exchanges. We have 77 members. They cover more than 20 million people across those three lines of business. They're all what we consider safety net plans. So many of them got their start from community health centers, from children's hospitals, public hospitals. Some are government-based, a lot of California ones. They're really very mission-driven types of health plans. They vary in size from some that have members, 5,000 members, up to other ones that have over 1 million members. So it's really quite the gamut. Many are sort of in between, but it's not just the for-profits and the blues plans that are out there trying to implement these interoperability rules. We have a lot of not-for-profit safety net plans that are trying to do that as well. The next slide is our mission. It's really mission and vision. It's really to strengthen those not-for-profit health safety net plans to improve the health and well-being of lower income people and people with significant health needs. We have a lot of complex care folks that are members, long-term care folks, duals. So there are really the folks who are in critical need of services. And our vision is really to have a country with accessible, affordable, high quality care, regardless of income, provided through coordinated care entities. We do believe that managed care is the proper vehicle and the most efficient and effective vehicle for providing care. Next slide is our goals. Is our goal still there? Maybe not. So we'll talk about our activities, our interoperability activities. So we have, we provided comments to CMS when the proposed rules came out. We were concerned on a number of policy issues and operational issues. The biggest issue was really the timeline. So we commented on that. We're thankful to CMS that they actually did announce that the enforcement of the implementation would be delayed for 6 months. So we appreciate that. We've been doing some educational workshops. We did those early on with a number of plans. 29 ACAP plans participated, almost 300 plan staff. They were all-day sessions, really setting the stage, setting the understanding the landscape, level setting for our plans to understand a variety of issues related to interoperability. We've been having ongoing roundtable calls on many of the issues that have been coming up. Those are available to all 77 of ACAP's member plans. And then we've been providing interoperability resources for our plans that are available to everyone, frequently asked questions, a 20-page document. We're taking the interoperability rules, really trying to make it easy to understand, give page references to a variety of the issues that the plans need to understand. We put together a vendor showcase. We know that many of our plans are not going to be building this themselves, not going to be trying to do this themselves, but really need to partner with a variety of what we call preferred vendors. So we had 12 preferred vendors do 1-hour webinars. They were able to do that twice for our plans, and we had a good number of our plans take advantage of that showcase to understand what the services available to them from vendors was. And then we do have our interoperability learning collaborative, really digging in deep on with educational webinars. We have a dedicated discussion forum, and 16 plans are participating in that collaborative. And Khoa will go into more detail with that. So Khoa Nguyen is the CEO of Nguyen Consulting, as Ricky mentioned. He's our consultant on this work. He's got a lot of experience. The next slide will show some of that. I'll get to that for a minute. Okay, wait, go back. So we also are going to hear from Mike Boeder. He's the Executive Director of Health Plan Operations at Children's Community Health Plan. That's in Milwaukee, Wisconsin. And then we also have Kim Sinclair, who's the Chief Information Officer at Boston Medical Center HealthNet Plan in Boston, and also doing business as WellSense Health Plan up in New Hampshire. So thank you to all three of you for participating and providing your insights into the work that you're doing on the ground. So the next slide is just a little more information on Khoa. He's had his consulting firm since 2018. You can see his current focus areas, working a lot in California with the plans there. He is located in California, and he has 20 years of experience in healthcare, including as the Chief Strategy Officer for the Health Plan of San Mateo, which is another ACAP member plan. And he is also a consultant at Avalier Health prior to that. So with that, I'm going to turn it over to Khoa to take things from here.
Thank you, Enrique. Can you hear me okay?
We can.
This is great. So for what I'd like to do is maybe just cover real quickly a couple of the items and really get to Mike and Kim, I think, so they have a lot of time to share about their unique experiences. But a couple of things that ACAP did that I worked with them on in the plans is as part of some early activities, just to getting a gauge to what their initial current state looks like relative to the interoperability rules. So what I'm going to share with you are just 2 slides from a market study of ACAP plans, where 20 plans submitted responses to a few questions. It was the lead at each of their plans for interoperability. And in the first one, we asked, to what extent were some really challenging sort of factors that were impacting their ability to implement. And what I show here on the slide, which I would suggest each of your plans who are out there, mostly again to the audience, to see what are the main challenges you have and how are you going to mitigate or respond to those challenges. Of those that are listed, I really just highlighted the ones where the 20 plans indicated it was very challenging or extremely challenging from a long list that was provided. And if you can see, just want to highlight the first couple of them on the top of the screen. Again, this was the final rule was released in March. This was in the middle of COVID. And irrespective of other things that are happening in, in your state or in your region, which was, probably already a priority, the COVID sort of crisis happened. But I think the other key piece that we really kind of focused on was the response back that, just understanding the requirements. Many of our staff were behind or maybe didn't follow the proposed rule as much. And, that 500 pages in the CMS rule is kind of a hard read. So that is a focus, is making sure the education awareness is there. So that I think represents many of our plans who are overwhelmed with just the degree and the scope of the requirements. And now the highlights of other, items that are on there, obviously some financial, some of the timing. And again, that got, a little bit better with the CMS 6-month enforcement date. On the next slide, if I can, this question just asked our plans, how would they evaluate their experience with some of the technical requirements in the rule? So you can see there's FHIR, there's USCDI, some of the identity management specs, and just APIs in general. And as you can see, the majority of them are indicating very little or even no experience at all with these requirements in the rule. So this is a starting point for a lot of our Medicaid safety net plans. So it's a lot of work, even with the 1-year time frame that we had to do, and you'll see that's why they're needing and looking for experts, vendors, and others to help them along the way, and ACAP being a resource to do that. So next slide, if you can. I just wanted to highlight one of the current core activities. Again, this, we're calling it a learning collaborative. This is building off of some earlier work that Mike and Kim and some of the other ACAP plans are participating in, where we did some early education and awareness to start as a grounding. And currently there's 16 plans working in a collaborative. And what that collaborative looks like, just so you know, it involves 8 educational webinars on very focused topics based on feedback from the plans. I kind of list here some of those examples. It was focused on just the budgeting, financial, some priorities in the discussion with CMS. We have one upcoming for FHIR and Hedis, as Hedis just announced a FHIR data model. So that's just an example. It's just focused areas. The other is just an ongoing forum when questions come up, because that's, every week there's always a new question, and we have a chat forum to do that. And the third is, in addition to education awareness, the vendor selection and sourcing was a big sort of ask and pain point. If you think about, dedicating 6 months by implementation, that meant really the fall period to have a really aggressive vendor RFP or RFQ process. And there was a lot of ask to support that. So what we did was help them with an RFP template and just do a little bit of market study of some of the vendors, in addition to that vendor showcase that ACAP supported as well. So that's just what our learning collaborative looks like. And I definitely want to thank the plans for participating, Mike and Kim, who I'm going to ask them a couple of questions to share with the audience, who are pretty active, and also Enrique and ACAP for creating that forum for the ACAP plans. So with that, I'm happy to answer questions about this kind of format, but I really want to dedicate most of this time for Kim and Mike, and also for them to take questions from the audience. So to get started, what I'd like to do, invite Mike Kim to join now. And what we have to start with the first question for each, maybe Mike, if you can go first on this one, is if you can just share a little bit of an overview just for the audience so that they're familiar with the nature of your plan, what programs you're in, your service area, the types of what your members look like. And then a little bit maybe just as for context, where you are in the process with your interoperability implementation.
Certainly. Thank you, Khoa, and everyone else for joining. Good afternoon to my East Coast colleagues, and good morning to everyone else. As Children's Community Health Plan, we're a licensed HMO in the state of Wisconsin. We're based out of Milwaukee, as Enrique referenced earlier. but we do service the majority of the state of Wisconsin. Primarily southeastern Wisconsin is where most of our enrollment is located, given the population is most dense in southeastern Wisconsin. We are in the Medicaid space as well as Marketplace. We have been in operations since 2006 in Medicaid, and in 2017 is when we joined Marketplace. We also operate a PIP, a prepaid inpatient health plan, specifically for kids in foster care in southeastern Wisconsin since 2014. All told, we have approximately 150,000 total members, the majority of them being in the Medicaid program in Wisconsin, referred to as Badger Care Plus. And for context, that represents we're the second largest Medicaid HMO in the state of Wisconsin, of about 14 or so different HMOs. Wisconsin actually has a fair amount of HMOs for its size. It's just the model in which our state government has pursued at this point. So a pretty competitive landscape. For us, we are provider owned. Children's Hospital and Health System is our parent. As I mentioned, we began and incorporated in 2005, but began business in 2006 as a health plan. And since then, Children's Hospital and Health System, now known as Children's Wisconsin, is approximately about a $1.3 billion organization. And now CCHP, Children's Community Health Plan, we represent about 30% of that. So we are continue to grow and are a significant component of our overall health systems diversification strategy. In terms of our enrollment, about 65% of our population are pediatric members, but 35% are adults. So that certainly makes us different or unique relative to our parent, which is exclusively focused on pediatric services. I guess, you know, the truth is, about this time last year, I was at ACAP's fall meeting, a little bit later than right about now, and there were some excellent presentations about interoperability. And I remember pretty distinctly having a conversation with Enrique later in that evening, saying, you know, I think we need a lot of help. We're learning a lot more about what we think this is. We've been hearing about this, but we're not really sure what it means. So I would say we began our journey in earnest, quite frankly, about a year ago today. We certainly knew about it prior to that, but that ACAP meeting in September was certainly a marker for us to begin our journey. And really since then, ACAP has been a very trusted resource and instrumental in our strategy and our decision making. We're an extremely active member in ACAP. My boss, our plan CEO, is on the board, and frankly, we are very fortunate and feel lucky to be a part of the ACAP group for this particular initiative. It's been an excellent experience. So what does that really mean? So since then, as Khoa referenced, obviously we began our scoping and strategy work in Q4 of last year in pretty significant detail, and stood up a steering committee involving our parent company colleagues who provide administrative resources to us in the form of information management, legal, risk, some of those other services that you might think of. And that, you know, developed our strategy really in Q1, and then of course, you know, COVID is our reality. So for us, it is all about what the high level slides that Khoa referenced in terms of competing priorities and managing around resources and staffing, while we're trying to understand what does this rule mean to us in our business. How do we prepare for execution? And not to bury the lead, but really, how does this make us a better plan and ultimately a better experience for providers and members, which is ultimately the end goal. So, you know, I mentioned we developed that steering committee. We also, you know, we've been very active with ACAP And then we also engaged in some expertise and consulting, and quite frankly, work with Khoa on that as well outside of ACAP. That's been instrumental to our strategy. From that, we developed our business strategy. We presented that to our board of directors, outlined what we knew, what our plan was, gave them a good understanding that this is going to cost a fair amount of money and to be prepared for that. And ultimately released an RFP a couple of weeks ago, and frankly are in the review of that process right now. And our goal is to have an interoperability vendor to support us selected by October for a November implementation, so that we're in position for that 6-month glide path period to be complete and ready to roll, essentially when the enforcement begins on July 1. So that's about my best 3-minute summary of interoperability in terms of where we are right now.
Thanks, Mike. Kim, you want to start?
Yeah, thank you, Khoa, and thank you, ACAP and One Up Health for having us today. I am the CIO at Boston Medical Center Health Plan. As Enrique mentioned, we also do business in New Hampshire as WellSense Health Plan, and we're part of the Boston Medical Center Health System, which includes Boston Medical Center, one of the largest health safety net hospitals in New England. So we were also hit by COVID, and that certainly factors in. We have programs, Medicaid in Massachusetts, and for that we are primarily in a new ACO model, new a couple of years, I guess, as well as MCO. We have Medicaid in New Hampshire. We're also on the exchange in Massachusetts, which is a state-based exchange, and we have a senior care options program in Massachusetts for seniors that are dually eligible. And we have about 410,000 members total. Can't remember if I shared that. Mostly low income and vulnerable populations. That's really where our focus has been. We are still very early on, I feel, in our interoperability journey. I think COVID definitely distracted us, as it did many, and the work with ACAP and the Learning Collaborative has definitely caught us up, I think, quite a bit. We've met with many vendors over the last few months, and that has been actually a very helpful process to learn not just what's going on with the technology solutions itself, but also educating us in some ways about the final rule and things we just didn't know, and have since come up with ACAP, and we've learned a lot. But that, I think, has put us in a better position to move forward now. So I'm feeling much better about that. But we were very much in the high risk of didn't really understand the requirements, as Khoa was talking about. And now we are assessing our data, as most are, looking for gaps. And we are not quite where Mike is. We are finalizing an RFP that we're hoping to get out very soon in the next week or two. We are planning to select a vendor for the platform, ideally November, contract with them and over the holidays, and kick our implementation off probably in early January. So that's where we are.
Thank you, Kim. If I can ask maybe one more to get started, and I want to invite the audience. I don't know if that's going to be done through, if we're going to see chat or if it's going to be moderated by One Up, but I'd like to just offer one other question for Mike and Kim, open it up, and obviously I know Enrique, SV, and myself, we have a ton of other questions that I think might be useful as well for the audience if we're not hearing or seeing anything. Mike, Kim, can you just share a little bit about how you're approaching the solutioning itself or for implementation? I know, ACAP 77 plan, everyone kind of has a different technology environment, some different business goals or situations. To the extent that you can share, what are some of the unique things that you're prioritizing in your vendor or just your approach to the solution, and what do you see as probably the most critical challenge that you're trying to overcome? Mike, or actually maybe Kim, why don't you start on this one first?
Sure. So we're, as I said, still pretty early on. I think one of the key components for us is looking at, where all of our data is, and what's going to work best to meet that need, and whether from a technology perspective and a fire perspective, we need to be looking at a facade or a repository type solution. I think we're leaning one way over the other, but that's something that we're trying to narrow down. And certainly, where the data is overall is there. The challenge for us is more about timing, and I don't mean that from a, well, everybody's got the same timeline, but we are actually in a position where we have multiple projects in flight that actually impact the data that's required for meeting the patient access API. So, for example, we're transitioning off of our current care management system to a new system. That's not new, it's been in progress, but wraps up this quarter, which means we're not as familiar with the data in the new system, and that's some of it's required to meet the final rule. We've also been working on an enterprise data warehouse initiative for a few years, and we're wrapping that up in the next, hopefully, 6 to 9 months. But it couldn't come at a worse time, as we're sort of transitioning from one to the other and looking at what additional work we're going to need to do to support interoperability while trying to minimize the work that results in rework later.
Yeah, thanks, Kim. And one thing to emphasize, than just talking about a lot of plans, it's not just planning for the requirements for just the rule, but also you're in the middle of transitioning vendor systems that all impact your data sourcing, and you need a plan for that because it can happen in the middle of it, soon after it, and that gets a little bit complex because of the uptime and data integrity issues. So thank you, Kim, for making those notes. Mike, you want to go next?
Yeah, a lot of those similar and same challenges. So we understand that well. In some ways, it's, where all of our business continuity plans are being tested with the proliferation of the impact of COVID and this rule, plus all of the other realities of whatever projects are already happening. So, we have a very similar, list of projects that we are managing at the same time. Determining how to prioritize the resources necessary and our strategy on interoperability within that is in of itself an ongoing task. It's something that really is my responsibility as much as anything. But outside of, the first thing for us, again, I mentioned was we really needed to understand these regulations and rules and its impact. I have to quote our Vice President of Corporate Compliance, who provides us support and is on our steering committee. I was preparing for a meeting with our board, and he said, a quote that you can share from me would be to your board is, this is as big as HIPAA, but nobody knows it yet. So I thought that, that stuck with me, and I think there's some relevance to that, because one of our challenges is not just beyond, or not just understanding the rules and regs, but how to explain this to other parts of our business and what it means to them in quality and in our clinical areas. Certainly when we start thinking about member outreach and communication strategies, third-party developers, et cetera, all of that factors into it. So a big part for us was just really going beyond the rules and regs, identifying our business strategy around this. And for us, again, provider-owned health plan. We have some administrative support services through our parent. After reviewing this, we realized we don't have experts to delegate this to. We are it. We have to figure this out. We needed some help. We extended our work to our external partners and ACAP and other resources to better understand its impact. We have some unique realities as well. We have 2 different trading partners, or key trading partners, 2 different third-party administrators that are a part of our business model for customer services and claims. So for our Medicaid line of business, we work with a plan in the state of Wisconsin as our third-party administrator for customer service and claims. And for our marketplace, we work with another plan that's outside of the state of Wisconsin for that. There's reasons for it. We won't get into that, but the reality is that's important when we think about all of our data sources, particularly claims, and how whomever we work with, that our vendor really understands who we are. And so we spent a lot of time in developing our work plan to really use that as the basis for our RFP to also then take, frankly, some of the things that we would normally spend time on during contracting, things like terms and conditions, our security addendum, et cetera, and incorporated that in the RFP. We went through the vendor showcase through ACAP to help vet who we thought would be the preferred providers for us to outreach to for our RFP process. And we had meetings with those vendors as well in advance of the release to help them understand us, and with all of that information incorporated into the RFP so that they could be in the best position to provide an individualized, tailored plan to our needs. I mentioned a couple of the things that we felt like that made us unique, including our TPA partners. And then obviously, we made a decision pretty early after learning more that we were going to be a buyer, not a builder, which is why we're in the RFP process, and we're all in on that. So that partner, I keep using the word partner. It can't just we move away from this idea of just this is our vendor. This has to be a trusted partner to help us with our interoperability solution that fits within our business model for years to come. And so for us, mapping out all of the sources, our architecture, our data strategy, all of that went into the work plan. And we have obviously detailed timelines and milestones that we are looking to hit. And I like him, I can assure you this, I feel a lot better than I did a year ago after talking to Enrique, thinking, man, we're in some trouble here. We need some support and some help. And we put the effort into it, and I think we're in a pretty good spot relative to our planning. Now it's about implementation and execution thereafter.
Thanks, Mike. I'm going to take a question from the audience, from Keith here, and others who want to jump in and ask. Please feel free to do so. But I think this is a question that follows up to your both Kim and Mike, your comments about just multiple initiatives, other stuff that's happening right at your health plans. Can you maybe share a little bit more whether it aligns with or not, and maybe how you're thinking about maybe the prioritization sort of exercise, Mike, you've referenced, relative maybe, how does it fit with maybe other broader interoperability or data sharing components that you're working on? So maybe not just the vendor transitions, Kim, that you mentioned, but your broader data sharing initiatives, and or specifically any kind of use cases that kind of stand out as part of your data strategy, either with providers, quality reporting, care coordination, anything that, again, it's still early and everyone's mostly focused on compliance, but if you could talk about, again, your broader initiatives and any specific use cases that kind of stick out to you. Maybe Mike, you want to, if you're ready.
Sure. So candidly, I think use cases are an area that remains a challenge for all of us to have the vision to see how this will improve our service delivery. So having some experience from others that are like us to share that has been helpful, especially as we think about that communication strategy to other parts within even my colleagues in clinical, as an example. So I'll build off of that, and I would say, when we think about quality and Hedis, and certainly that's an area that even through ACAP we continue to learn more from, and CQA, and what they think about the interoperability relative to NCQA and Hedis. But that's an area that for sure strikes us as a real opportunity to build on, what all health plans are constantly doing, which is trying to improve our quality scores. So how this initiative, how interoperability can enhance those opportunities. So down to the granular level of less chart chasing, as an example, things like that. So there are many. That's a very small granular level, but the truth is, all of that counts, and there's a lot of efficiencies and economies of scale like that we believe and we think can be a part of this interoperability solution. But use cases, again, to start off, frankly, that's an area where we need to understand those better, because they're more theoretical right now than not.
Yeah, I would agree with what Mike has shared certainly about quality and Hedis, and that seems like a really good opportunity. We'll learn more when we speak with NCQA later this month. I think we are still as well defining our use cases, but I think there are lots of opportunities that we've certainly started to talk about internally. We don't, as Medicaid plans, we're lucky if we get claims when a new member enrolls. It can be months before you identify that someone needs care management. So the ability to get clinical data, certainly that's more with likely with the payer-to-payer than maybe the patient access API. But being able to identify members earlier that need care management, need some assistance, need transportation or whatever the case may be. So we're really looking forward to see what those look like. But more broadly, for us, this isn't just about compliance. It's about having something to build off of for interoperability. It's definitely a pain point for us. And I think there are many use cases that we'll find to support it.
Thank you, Kim. And I think, Christina, there's been a number of questions posted. Do you want to read those off? I'm happy to share, but I don't know if I have access to the YouTube channel right now.
Yeah, definitely. So one of the questions someone asked is, what do you see as the items most underestimated by health plans in terms of complexity and effort in meeting the CMS mandate requirements?
For me, I would say it's the data and really understanding. I think we all understand claims from a health plan perspective really well, but when you start to get into the clinical data and how it really translates to FHIR and that it's going to be meaningful in that way, that you're doing it correctly, I think that's a vast area that will probably take more time than any of us expects.
I could not agree more. And I know, again, through the ACAP conversations, I guess I'll call it the opportunity there that appears to be present is that there are some interpretations, even as we understand that in terms of, what's in or out of scope from a clinical data standpoint. Example, PDF scans that come through WriteFax or some other form that isn't in a very easily discernible, collectible format. That how that translates to the clinical world beyond claims is part of our data strategy and organizing our information. I think another thing is, again, back to just what is this going to look like from the members' perspective yet. The sort of the third-party app component of this, I think it seems to be a bit of an unknown yet for us to see exactly what that's going to look and feel like for our members. And obviously we want to put this in a position to where this is something that has a high utilization, and I think there's a lot of skepticism about that, and so we want to make sure that this is, again, back to that, this is going beyond compliance and that this is user-friendly to our members and is creating value to our health plan.
And if I can, just to echo a little bit of and add to what Mike mentioned, I think just from my experience working with a lot of the plans in ACAP California and others is, I don't know if underestimate is the right word, but I think just the lack of sort of experience, our plans don't have experience with consent management and the notion of working with third-party apps outside of their own, maybe in a few cases their own mobile app. That's all new territory. And I think sometimes with vendor solutions who are promising that ability to really do well and support access management with consent and identity management, that I think that's hard to discern from the many vendors who are pushing out more just fire API solutions. So I think to many of our plans is figuring out who's really good at that in addition to the fire support, the fire server API support. Christine, is there other questions?
Yeah, one more question in the last couple of minutes we have left. The other question is, are there any other forums where you all are collaborating with other health plans to share lessons learned and best practices?
I can jump in. We certainly have that opportunity through our state association, so the health plans that we work with within our state association, and we have leveraged that. I will say, candidly, we have much more freedom of information flow through ACAP than we do even our state association, though. Maybe that has something to do with competitive landscape, perhaps, but you know, we definitely are having those conversations, and we, for us, because we have two different TPA partners, as I referenced earlier, both of them are also providing services in the Medicaid and marketplace space. So they have an understanding of what this feels like to implement themselves as well. So that's been a natural built-in partnership, and frankly has strengthened our relationship with really both of those TPAs, to which was already strong. So that's been very helpful.
Can I just maybe add one more, just other forums, because I work with a lot of the California safety net plans. There's 16 of them. Most of them are members of ACAP, but there's been sort of dedicated forums that there's a little bit of a history of a lot of the California Medicaid plans working together, and we almost have like a separate sort of forum to do that in addition to ACAP. 7 of them, you know, worked on a special strategy and planning grant. So that's just an example of, and they're looking at some other opportunities to collaborate both on education and some of the implementation. And you know, there's some early discussions that our ACAP plans are going to find out pretty soon. Is we're talking with a potential collaboration with states. Again, state fee-for-service have to do a lot of the same requirements, and they're behind just as much as, and trying to figure it out just as much as the plans, and they want to have an active discussion. That, I think that's good for our plans, because that can also help maybe shape and inform any guidance that the state may share as well on the stuff that CMS doesn't. If I can ask, maybe in the interest of time, one question. Mike, you mentioned this, but Kim, if you can add, and it a little ties back to the underestimating pieces to your steering committee, and I'm not sure a lot of other health plans out there appreciate how important this is to incorporate the business side, not just your IT and technical side to this. And can you share, Mike, a little bit of the makeup of your steering committee, their role, and what you thought, how that's helped you, but also why that's important? And then maybe, Kim, I don't know, to the extent that you have, how you've incorporated, or some of the challenges with doing this beyond just an IT project.
Sure, I'll jump in first. Thanks, Khoa. And so by the nature of my role and my background, you know, so I'm not the IT leader. I mentioned a little bit about our infrastructure. So one of the values we have that, you know, we really lean into and implement is collaboration and integration, whether it, you know, those are 2 values, but really that are as part of our business model. In this case, it's not only not just part of our values, it's prudent. It's what we have to do. So because, you know, it's my responsibility to roll this project out, it requires us to have the right people on the bus, so to speak, both internally and externally. So for our steering committee, that is including of our chief legal support. So our health plan lawyer, legal analyst is on our committee. Our chief compliance officer from our corporate compliance, leadership from our information management systems, reporting and analytics, which is through the health plan. Obviously, myself, we have added, in a key component for us is we knew early on we needed to assign a project manager to help support this as well. So we have our reporting and analytics lead, Matt Krause, who's probably listening in on this right now, who's been instrumental. And we've dedicated at least 50% of his time over the next 12 months to this project. So there's all sorts of hidden and sunk costs, clearly. And now we have our medical directors, our clinical and quality people are on our committee as well, because this has to expand much beyond a tech project.